Well, thank you for inviting me along. I'll just give you a little bit of background. I've worked at Peter Mac, as Kate said, for quite a number of years in the pharmacy department, and I've worked across all the areas, but in about the last 10 years I've stayed in clinical trials where we support the clinical trial service, prepare the drugs, dispense them, and it's been a really interesting area to work in, especially in the last 10 years, because there's been a lot of changes and a lot of developments in cancer therapy. So it's really quite exciting, and I think it'll offer quite a lot of opportunities for people with your tumours. So neuroendocrine tumours, and I've got a picture up there with a whole lot of little numbers and things beside it, and I'll come back to that at the end and perhaps it'll make a little bit more sense to you. So for neuroendocrine tumours, because they range across various areas in the body, and also because they have different growth trajectories, there's numerous different treatment options, and some treat certain tumour types and certain tumour locations. So there's a variety of treatments. Two main types of NETs, and we usually divide them into either carcinoid or pancreatic NETs, and that often directs what treatment you have. And as I said, there's a lot of treatments, and they include chemotherapies, targeted therapies, the somatostatin analogues, liver-directed therapies, and peptide receptor radionuclide therapy, which I'll go into. So if we start with the somatostatin analogues, they're usually the first treatment that people have when they develop NETs. And that's because there's a lot of what they call somatostatin receptors on the surface of the cells of the NET tumours, and they seem to have more of these somatostatin receptors than normal cells, and so therefore it selects, the treatment selects for the tumour cells. So the two main somatostatin analogues are octreotide and lanreotide. They're administered subcutaneously, intravenously or intramuscularly. Usually when you're put on these, you start off with them subcutaneously, and they're given to sort of control the symptoms of your tumour, and then once you've become sort of settled, you go to once a month injections. And they usually very well control the hyposecretion associated symptoms such as diarrhoea and flushing. But they can also inhibit the growth of the tumour, and there's been trials to show that even if you don't have any of the hypersecretion activity, they can also still act to inhibit the growth of the tumour. There's a new somatostatin analogue that we've had clinical trials on called pasireotide, and that seems to be more effective and has shown very encouraging results. At the moment it's not available in Australia, but I think it probably will shortly because the trials are now finished with that drug. All these drugs, like all drugs, have side effects, but they tend to be usually fairly mild and tolerable. They can cause nausea, bloating. They can affect your liver, and usually you need to have your liver function regularly tested while you're on these drugs. And they can also sometimes cause rises in blood sugar, so if anybody's got blood sugar issues with diabetes, that's something that needs to be also monitored really closely. And so they can also interact with any drugs that affect your blood sugar. So moving on from the somatostatin analogues, sort of associated, and it's not really pharmacy, but it's sort of associated, is the peptide receptor radionuclide therapy. And what they do is they radio-label a peptide, which they then attach to your somatostatin analogue, so your octreotide usually, and that means that the octreotide can carry the radio-labelled peptide to the tumour. It's usually given with 4 induction courses, once every 6 weeks, and then maintenance therapy, perhaps 12 or 18 months. So a number of treatments. When you have the treatment, you also have to have an amino acid IV solution given to you, and that's to protect your kidneys, because the drug's cleared through the kidneys, and so you get concentration of the radioactivity into your kidneys, which can cause damage to your kidneys if you don't have this amino acid solution. So that's just a little cartoon, a bit how it works. So where the purple is the cell wall. Up above it you've got your OC, which is your octreotide, which is your somatostatin analogue, with its payload attached, and there's various different radioactive peptides they can attach. The octreotide goes and attaches to the somatostatin receptor, which is on the cell wall, and is internalised into the cell, and it carries its radioactive payload through into the cell, where it then causes radioactivity which kills the cell. So it acts by killing the cell with the radioactivity, and you also get what's called bystander killing, whereas the radioactivity doesn't just stay within the cell, it can actually hit the cells around the cell that's got the analogue in it, so you get quite a big kill. So this is a really effective treatment. It's usually long-lasting and really works well for certain types of tumour. If we move on from there, chemotherapy is one of the mainstays of treatment. There's various different agents used depending on what sort of tumour you've got and where it's located, but some of the main drugs used is 5-fluorouracil or 5-FU, and that's given as an intravenous infusion, often a long-acting infusion over 3 weeks, and then you have a week off and then come back again. There's also capecitabine, which are tablets, which are given orally, and they're taken twice a day for 14 days, and then you have a 7-day rest, and then start another course. They can combine capecitabine with another drug called temozolomide, and that's a very effective combination, which probably a number of you may have already had. The capecitabine, again, is given for 14 days, and for the last 5 days, so days 10 to 14, you also have temozolomide, which is taken once a day, again as an oral tablet, and then you have a 7-day break before you start again. Streptozotocin is an old drug that's been around for a very long time, but is still very effective. It can be given alone, although it's often combined with another drug called doxorubicin or maybe 5-fluorouracil. It's given as an IV infusion. Then there's other agents that can be given: cisplatin, carboplatin, etoposide, irinotecan, dacarbazine have all been used to treat NETs. Carboplatin etoposide as a combination is quite a common treatment and very effective. The problem with chemotherapy is they do have side effects. Usually most of the drugs can cause nausea and vomiting, but these days we have some very effective agents that have been developed especially for chemotherapy, nausea and vomiting, and can control that. People get fatigue. It affects your blood counts, and you can get low blood counts, which gives you an increased risk of infection, so you need to be careful when you're on chemotherapy. Also, the blood counts can increase your risk of bleeding, and CapTem, which is capecitabine, temozolomide, the combination I mentioned before, is known to do that. People can lose their hair. Capecitabine and 5-FU are known to cause skin rashes, and especially they cause rashes on the hands and the feet, called hand-foot syndrome. And it's really important, any sign of that you use moisturising creams, often to wear gloves on your hands to stop your hands being barked or chafed, and also to keep out of direct or strong sunlight can help. If it gets worse, your doctor can give you, cortisone creams and things that can help if the rash gets worse. Doxorubicin's associated with heart effects, and you'll always have your heart monitored if you take that drug. And streptozotocin has been associated with kidney effects, and that means your kidney function would always have to be well monitored if you're on that drug. When you're on chemotherapy, you need to avoid certain natural therapies, and especially the ones that might increase bleeding, such as fish oils, fenugreek and reishi mushroom. And at the end of my talk, I've got some lists of natural medicines that perhaps you should avoid when you're taking various therapies, which you can, a bit more than just I've got here. And also some lists of antioxidant therapies. So everolimus is an interesting drug, which is a fairly new drug that's been developed and has shown great activity in nets, both in pancreatic nets and also carcinoid nets. Unfortunately, at the moment, it's only on the PBS for pancreatic nets. However, it is approved for carcinoid nets. It's taken as a tablet, so it's an oral tablet, and sometimes it can be combined very effectively with octreotide, the somatostatin analogue, and sometimes with other chemotherapy agents such as temozolomide or a drug called bevacizumab, which I'll talk about in a moment. Again, it's not without its side effects. It quite often causes nausea and vomiting and stomatitis, which means sort of ulcers and things in your mouth and down your throat. It also causes rash, dry skin, nail or disorders, and can cause this hand-foot syndrome. People often get a cough while they're on it, nosebleeds, fatigue, increased risk of infections again, and also it can affect blood sugars. So again, I've got a little cartoon, a bit about how everolimus works, because it's an interesting drug. It sort of has a two-pronged effect. First of all, it attaches to the growth factor, which is on the cell wall, which are those lines across the top, and it can go in, and it's called an mTOR inhibitor. mTOR is the name of one of the enzymes within the cell which acts with some of the cell pathways specifically involved in cell growth and proliferation. So by blocking that, you're blocking cell growth. It also blocks the cell metabolism within the cell, which means the cell can't work well and it tends to die. And it also does something which is listed in the middle there called angiogenesis. Now, angiogenesis is growth of blood vessels that tumours get to grow to supply blood as they're growing. Every cell in the body needs a blood supply because that's what carries nutrients and oxygens to the cell so they can stay alive. So when you've got a tumour growing, what it does is it produces these growth factors which causes the blood vessels to grow new blood vessels over the surface of the tumour so that the tumour can continue to grow and be provided with nutrients. Now, a drug like everolimus is an anti-angiogenesis drug, so it blocks the growth factors which cause the growth of the new blood vessels and therefore starves the tumour of oxygen and nutrients, and they die back. So it has that two-pronged approach, which is why it's such an effective drug. So bevacizumab is the drug I mentioned before, and it was also an anti-angiogenesis agent. And there's a bit of a picture on the bottom corner there showing the new blood vessels that have grown over the tumour as the tumour grows, and then the angiogenesis agent comes in, blocks those growths, destroys the blood vessels, and therefore starves the growing tumour of nutrients and oxygen and causes it to die. So bevacizumab is a drug that's given intravenously. It's the first angiogenesis agent that was marketed in Australia. It's been shown to be very effective when it's combined with everolimus or temozolomide, especially in pancreatic nets. Again, it's got side effects, a high risk of infection, and people often take antiviral and antibiotic drugs while they're on this drug to give them more cover from infection. It also causes an increased in risk of bleeding, which is probably pretty obvious from the way it works because it tends to break down and make the cell walls of the blood vessels a little bit more friable, so it means you've got an increased risk of bleeding. Sunitinib is another oral agent that's is effective in nets and is on the PBS for pancreatic nets again, but it's also been shown to have activity in carcinoid nets. It mainly acts as an anti-angiogenesis agent, although it has other enzyme activity and acts on other pathways within the cell as well. So it sort of has a multiple effect on the growing cells. It does cause side effects, again, a similar constellation of side effects from the other agents that I've talked about. A couple of other anti-angiogenesis agents which have been in clinical trials and have shown activity are azanopib and sorafenib. These drugs are both marketed in Australia, but they're not indicated for neuroendocrine tumours at the moment, but possibly that'll change as the results of the clinical trials become known and the TGA may recognise them for this indication. They're both taken orally. They have similar side effects to sunitinib. Sorafenib's mostly associated with fatigue and skin rashes, whereas pazopanib can cause hair colour changes, which is quite strange, low blood sugar levels, and it can affect the liver. And I've also read about another drug called sulfatinib, which has been in clinical trials in Europe, but it hasn't come to Australia at all yet, and it's also shown some good promise in early clinical trials. So that's another one sort of on the horizon. For people who have very difficult to treat hypersecretion issues that are not really controlled with somatostatin analogues, they can give interferon. It's not usually used as an upfront treatment because it's quite a difficult drug. It's got quite a large number of side effects and a lot of people have a lot of trouble tolerating the drug. It's given by injection subcutaneously every day or every other day. And as I said, it's often not used because of fairly significant side effects such as depression and fatigue, causes flu-like symptoms, increased risk of infections, and it can affect the thyroid. But for the patients who can tolerate the drug, and there's some people who don't seem to suffer too many side effects with it, it can be very effective in controlling carcinoid-type symptoms. So moving on to clinical trials that I've seen since I've worked at Peter MacCallum. The first one is this pasireotide, which is the new somatostatin analogue given by monthly injections, has a similar side effects to the normal somatostatin analogues, although it seems to be worse, has a stronger effect on blood sugar levels, so they have to be monitored closely. But it seems to be a very effective agent, and I think it'll probably be marketed in Australia soon, so that's another option as a somatostatin analogue. Teletristat etiparate was another drug that we had on trial just a couple of years ago. The trials have now closed, but it acts on the cells in the gut wall that release serotonin, and it's been thought that serotonin is actually responsible for a lot of the carcinoid syndrome type effects like diarrhoea, flushing, but also the heart damage you can get from carcinoid syndromes. It's taken orally twice a day, seemed to be very well tolerated. Side effects listed as constipation and headache, but I don't think there was a very high incidence of those. So it's another drug that's coming soon. Clinical trials are finished, so look out for that. I'll hopefully be marketed fairly soon. We have a trial at the moment with these SIR spheres, or yttrium-90 microspheres, and these are tiny little spheres that are made by a company that also have a radioactive payload, and they're administered directly into the liver portal, and they're very good for liver cancer, but also for nets that have got liver involvement. The most exciting new therapies in cancer recently have been the immunotherapies. For a long time, nobody's really understood why the body's immune system doesn't attack growing cancers, and it's been found that the cancers have these receptors on their cell walls that seem to block the immune response in patients and therefore allow their tumours to grow. So they've now been able to develop some drugs that actually block these receptors on the cells of the tumour and therefore allow the normal body's immune system to attack the tumour and kill them. And so they talk about upregulating the body's immune system. So they've had very good effect on a number of different types of tumours. Of course, the main tumours they've been tried in are the common tumours, like it started off with melanoma, but lung cancers, breast cancers, they've tried them in. A lot of those tumours and rare cancers like NETs tend to be forgotten when it comes to clinical trials because, one, there's not a lot of money in NETs, and two, there's not a lot of patients, so it's hard to get the numbers to recruit to a clinical trial to get really good results. However, there's a new type of clinical trial that seems to be coming around because they're able to look at people's tumour cells much more closely these days. They can look at the receptors on the cell walls, and they can also look inside the tumour at the genome and look at the DNA mutations. And so now we've got a new type of trial that's been developed which are called basket trials, where rather than saying we're going to do a trial in breast cancer or something, they say we're going to do a trial for all tumours that show a high number of certain type of receptor on the cell wall, which means it doesn't matter what sort of tumour you've got. If your tumour shows expression of what they call biomarkers, which are these receptors on the cell wall, you could be eligible for the trial. And I think that's going to open up clinical trials to a lot of people with rarer type cancers who up till now have had trouble getting access to the newer therapies as they come along. So at the moment at Peter MacCallum, we've got a trial with a drug called pembrolizumab, which is an immunotherapy drug, and it is a trial for any tumours that express what they call the PD-L1 biomarker, which is a receptor on the cell wall that's associated with the immune response. And so all different types of tumours, people with different types of tumours are being recruited onto this trial, and a lot of them are doing very well. Pembrolizumab is a drug that's given by intravenous infusion. It's, I think it's a half-hour or a 1-hour infusion given once every 3 weeks. So it's, you know, not too time-consuming. It's generally well tolerated, although people can get some hypersensitivity reactions when they first get given the infusion, but they're usually able to be well controlled within the hospital. They usually only happen in the first couple of infusions, and after that people seem to tolerate it better. The other side effects you can get are autoimmune type side effects. Because your immune system's been upregulated, sometimes it can go and attack your body's normal cells, and so you can get sort of autoimmune type symptoms. So often it seems to attack the thyroid, and we can control that by giving you thyroid supplements. It also sometimes attacks the cell wall of the gut, so people get colitis, cramping pains and diarrhoea. Again, we've got drugs that we can use to treat that. So mostly people seem to tolerate these immune therapies really well. And just recently at Peter MacCallum, we've had a new trial open up, again using 2 different immunotherapy drugs, one called ipilimumab and the other one nivolumab. And this trial's been opened up specially for rare cancers. And they've listed 3 types of rare cancers, and one of those types is neuroendocrine tumours, both carcinoid and pancreatic. And this trial's open at both Peter MacCallum and the Austin Hospital. You start off getting 2 drugs, ipilimumab and nivolumab, are given once every 3 weeks together, one and then the other, for 4 doses, and then after that you continue on with just the nivolumab every 2 weeks. Ipilimumab seems to be associated with more side effects, so normally the only 4 doses are given. That seems to be about as much as people can tolerate before the side effects seem to come in. and then you can stay on maintenance therapy on the nivolumab for up to 2 years. So again, we're really hopeful that that might really offer help to people with rare cancers. And that's about all I've got, except that now I've got the picture there that I started with of the various sites of neuroendocrine tumours, and all those numbers and lists at the side are the various different mutations and things that they've found in these tumours. And the biochemists are working like mad trying to develop drugs that will attack all these different mutations. So we've got new drugs coming through all the time on trials that target different mutations. Sometimes they work, sometimes they don't, but when they work, sometimes they can be really great. And just a little bit about natural medicines, which I haven't really touched on much at all, but just to remind you that just because it's natural doesn't mean it's necessarily safe. They still can have effects, they can still interact with the various other drugs that you might be taking, and they can interact with the chemotherapy or the treatment, the cancer treatment that you might be receiving. So I just sort of came up with a list of some of the more common ones that you might be interested in. These are the natural medicines that you probably should avoid when you're on chemotherapy, either because they act as antioxidants, and that seems to block the way that chemotherapy works. So it's probably best not to take them because you want to get the maximum benefit that you can from chemotherapy. Also, some of them, like fish oil and fenugreek, can cause increase in bleeding. Chemotherapy tends to have that effect anyway, so you don't want to exacerbate it when you're on chemotherapy.
So could I just ask, so when you're on chemo, so just say if your chemo was 3 days once a month, can you have it sort of for the 3 weeks that you're not on chemotherapy, or you should avoid it altogether?
It depends on the action of the drug. If it's an antioxidant, it's probably, if you just don't take it for a few days either side, it'd be fine. But the ones that cause bleeding, chemotherapy tends to have a long action. It tends to take 2 or 3 weeks for your blood levels to recover after chemotherapy. So right through that time, you're at a higher risk of bleeding. So you probably don't want to take something that could also cause bleeding.
Something like ginger, that's not... Ginger's...
I don't think ginger's a problem. Not with chemotherapy. Oh, it's on the list.
It was on the list, on the last
Oh, it was on the list, was it?
So we just put a lot of ginger in food and stuff like that.
It's fine. Look, what I'm talking about is extra supplements. Okay. The amount that you eat in a normal diet or in your food is not going to be a problem. It's just if you're taking extra supplements and you're taking increased doses of these things. Just normal levels are not a problem. Yeah.
I'm actually on Q10 because I've been on some statins for quite a number of years. It's interesting that with some of the statins that you're referring to with the actual tumour itself, is there much evidence to suggest that the normal use of statins can increase your risk of net formation?
No.
Not really?
No, I don't think so. Not a problem. Everolimus, as I said, it's got this two-pronged attack. It can also cause anti-angiogenesis, which means you're at greater risk of bleeding, so you want to avoid any of the drugs that cause bleeding. It also acts in the liver when it's broken down to actually interact with some other medicines, and so that's why there's some of these things on there shouldn't be taken, because it can interact with those medicines and either increase or decrease the levels of them, which can cause toxicity. So it's got a number of different actions, everolimus. So you need to really check if you're on that drug with people what else you can take, and we can look it up and let you know if it's safe to take with everolimus or not.
Carol, can I ask, with the grapefruit, I remember in other clinical areas when we actually used to give patients grapefruit juice with some of their therapies in a different disease type, because it was shown that it increased the absorption of that drug. just wondering with grapefruit and everolimus, is it like that? And therefore, is it just avoiding grapefruit around the time of administration? Can you have it later in the day? And would one grapefruit be okay? It's just not having 10?
Yeah.
Like
You can, yes, although grapefruit is an inhibitor of some of the enzymes in the liver that break down drugs like everolimus. So if you take too much grapefruit, you can get increased levels of everolimus, and you can then run into a lot of toxicities and side effects. So grapefruit is known to have quite a strong effect in the liver, which is why they often tell you not to take grapefruit with quite a number of different drugs. Again, St John's wort is another one that works strongly, or hypericin, I think is the name of the drug, works quite strongly in the liver and can also affect the breakdown of the drugs that you might be in. So that might be a good thing if you're doing it purposely to increase blood levels, but if it's done without control, you can run into toxic side effects.
So if you were having grapefruit a couple of times a week or a cup of green tea occasionally,
you'd probably be fine,
yeah,
but you know, I wouldn't be having grapefruit every morning for breakfast or anything. I tend to avoid it. But you know, if somebody gives you a grapefruit juice occasionally, it's not a big problem. So all the list of things that I've got there all act on the immune system in various ways. Sometimes they say they're enhancers, sometimes they say they affect the immune system. We're really not quite sure what they do, and so we generally advise people not to take any of these things if they're having immune therapy. Because immune therapy seems to be so effective, the last thing you want to do is reduce the effectiveness by taking something that might interact and reduce the effectiveness. So that's a sort of, again, a list with quite a number of the same drugs on it that seem to have an effect on the immune system. So best avoid it if you're taking immune drugs. And that's just a list of some of the therapies that can affect blood sugar levels. So if you're taking a drug that also can affect blood sugar levels, probably best to avoid these natural medicines because you might end up with problems with your blood sugar levels, and especially if you're inclined to diabetes or you've got diabetes, that, you know, that's a special worry when you're taking those. And I think that's all I've got. So I'm happy to take questions if anybody's got any. I hope that covered the sort of things that you wanted to ask. At Peter MacCallum, we've got some people who work in what we call medicines information, and they've done a huge amount of work on natural medicines and herbs and things. So we can advise people whether they can take it with their chemotherapy and not. And they've given me a whole lot of their cards which I can hand out. So if you are taking anything, or you'd like to, or you're interested in any of them, they're very happy for you to either ring or email them, and they'll look into it for you. And they can give you much better answers than I can.
Is that available for non-PMA patients?
Yes, anybody can ring in. Yes,
Fantastic.
yeah, ring in, and as I said, they've become quite expert. They also tell me, the Sloan Kettering website. Sloan Kettering is a big cancer hospital in the United States. If you go onto their website, apparently they've got a free-to-use website about herbs and natural medicines that anybody can access. You don't have to be, you know, a medical person. It's free access to anybody. So it might be worth looking.
I'll put the link to that up in the Facebook group,
yes,
and attach it to the video. So yeah,
might be.
That all the time.
Yeah, so if you like looking around on the internet, browsing that, apparently that's a really good website, and really lots of information on it that might be useful.